This is a supplement to the chapter on chordomas and chondrosarcomas from Humans and Win Neurological Surgery, 8th edition. Here we provide an overview of this lecture, which will begin with a focus on common themes in the treatment of primary vertebral column tumors. This will be followed by individual descriptions of chondrosarcoma and chordoma. We will finish with a brief summary, including a mention of ongoing areas of investigation. We start by noting that primary tumors of the skull base and vertebral column are exceptionally rare, with an estimated annual incidence of 0.53 per 100,000 persons. Of these, only 60% of lesions are malignant. Because of the rarity of these tumors, treatment is likely to be performed only at high-volume tertiary care centers. However, we believe that it is important for all neurosurgeons to be aware of their existence. Currently, the gold standard for treatment of both chordoma and chondrosarcoma is surgical resection, where possible. Due to the rarity of these lesions, both of which occur in fewer than 1 in every 100,000 persons, it is near impossible to identify treatment algorithms based upon high-quality data. As a result, most of the recommendations are based upon case series and expert opinion. In both lesion types, surgical resection should focus on maximal surgical resection, as this has a demonstrable positive impact on survival. Similarly, both lesion types are considered radioresistant in that they show only minimal response to conventional radiation doses. Consequently, where radiation is considered as the therapeutic modality, it should involve high-dose, focused modalities such as LINAC-based photon systems, proton therapy, or charged particle therapy, such as carbon ion therapy. The degree to which radiation is thought to influence overall and disease-free survival is mixed in the literature. However, studies in the past 10 years tend to favor its use. The presumption is that radiation may help to address microscopic metastases, small foci located just outside the gross tumor margin, which are unlikely to appear on preoperative imaging and therefore may be excluded by the surgical margins. There is little evidence to suggest that chemotherapy is valuable as part of first-line treatment in either patients with chordoma or those with chondrosarcoma. However, there are many ongoing trials investigating non-conventional therapies such as PD-1 and EGFR inhibitors. Additionally, some have recommended the use of doxorubicin-based therapies for refractory or metastatic chondrosarcoma, as it has demonstrable efficacy for those with osteosarcoma. Here we present a version of Table 179-1 from the chapter. It summarizes the differential for primary tumors of the axial skeleton and has been simplified for presentation on this slide. It is provided as a table of reference and will not be covered in depth in this presentation. A surgical intervention is considered the mainstay for the treatment of both chordoma and chondrosarcoma. We present here a brief overview of the process of surgical staging for primary lesions of the spine and skull base. Metastases are relatively uncommon at the time of presentation in both patients with chordoma and those with chondrosarcoma. Nevertheless, the presence of distant metastases at the time of presentation is uniformly considered a poor prognostic factor, and in the hands of most surgeons is considered to be a contraindication to surgical intervention. The gold standard for staging is whole-body CT PET. However, given the proclivity for both chordoma and chondrosarcoma to metastasize to the lungs versus other sites, acquisition of a contrast-enhanced CT with chest, abdomen, and pelvis windowing may be considered reasonable. After demonstrating that the patient's lesion is localized, the lesion should then be biopsied to confirm pathology. We prefer CT-guided biopsy over fine needle aspiration. However, the evidence favoring CT-guided biopsy is weak. Based upon the results of the lesion biopsy, the lesion should then be staged using the Inneking grading system, which was first published in 1980 and has since been adopted by the Musculoskeletal Tumor Society. This system categorizes lesions based upon histological grade or aggressiveness, the extent and local invasiveness, and the presence of metastases. Non-metastatic chordoma is usually categorized as stage 1, a low-grade malignant tumor, but chondrosarcoma can be either stage 1 or 2, the latter of which is considered high-grade. A and B suffixes are added to denote whether the lesion is confined within the single anatomical compartment, i.e. the vertebra for spinal lesions, or is locally invasive. In spinal and sacral lesions that are considered surgically resectable, the system of Weinstein, Boriani, and Biagini is used to identify the ideal surgical approach. This system categorizes each vertebra as a compartment, which is then divided into radial sectors labeled 1 through 12, and concentric tissue labels labeled A3, as indicated in the figure on the right. Previous population-based studies have reported that the annual incidence of chondrosarcoma is roughly 0.5 per 100,000 persons. Affected persons are predominantly middle-aged and male, with results from the SEER database suggesting that racial breakdown is similar to the overall racial makeup of the United States population. Chondrosarcoma can be broken down into roughly a half dozen histological types. However, nearly 90% of cases affecting the spine and skull base are considered conventional type. Lesions of the spine disproportionately affect the sacrum, localizing to the mobile spine in only 20% of cases. Median overall survival is poorer than in chordoma, with 5 and 10-year overall survivals of 53% and 43% respectively. Positive predictors of overall survival include smaller tumor size, younger patient age at the time of diagnosis, lower tumor grade, and contained versus localized disease. Mesenchymal and dedifferentiated histologies are thought to have poorer outcomes than conventional type. Chondrosarcomas derive from dedifferentiated chondrocytes and are characterized by the degree of cellular atypia, presence of mitotic figures, and characteristics of their matrix. The most common lesion type is the conventional chondrosarcoma, which is characterized by sparse cells with small round nuclei that are interspersed in a hyaline cartilage matrix, frequently organized into irregularly shaped lobules. Lesions with only mild atypia and absent mitotic figures are categorized as WHO grade 1, whereas lesions with mitotic figures and less abundant matrix are classified as WHO grade 2. WHO grade 3 lesions are said to be dedifferentiated and are characterized by high levels of atypia, nuclear pleomorphism, and abundant mitotic figures. Molecular markers in chondrosarcoma of the exoskeleton are less well studied than those of chordoma, though it has been noted that a low Ki-67 index predicts increased overall survival. Lesions generally stain negative for brachyury and epithelial markers, which helps to further distinguish it from chordoma. Several genes implicated in the oncogenesis of chondrosarcoma include those of the Indian hedgehog pathway, such as exostosin 1 and 2, and the hypoxia response pathway, such as HIF1 alpha, IDH1, and IDH2. It has been noted that IDH1 and IDH2 mutations correlate with poor overall survival. Overall, chondrosarcoma treatment is dictated by tumor grade and metastatic disease at the time of treatment. On the subsequent slides, we provide a possible algorithm for the treatment of patients with chondrosarcoma of the skull base and spine. In all non-metastatic cases, surgical intervention has a role, given the patient is willing to tolerate the morbidity of surgery. Radiation, by contrast, has little evidence to suggest its effectiveness as a monotherapy or as an adjuvant to surgical resection for low-grade lesions. It may be useful, however, in patients unwilling or unable to tolerate surgery. Chemotherapy is considered second line, but may be pursued in patients with positive margins, multiply recurrent disease, or who are too ill for surgical intervention. Doxorubicin-based regimens have been suggested to have success, with some prior authors employing the MAP regimen previously described for osteosarcoma of the extremities. We present the algorithm. For contained and locally invasive lesions, the treatment paradigm hinges almost exclusively upon tumor grade. Low-grade lesions, also known as WHO grade 1, can usually be treated successfully with en-bloc resection. If biopsy confirms negative margins, patients may reasonably be followed with observation alone. Where margins are positive, focused radiation may be considered. However, there is sparse evidence to support its efficacy. Following local recurrence, repeat en-bloc resection should be considered, given that it would not require excessive surgical morbidity. Following repeat resection, adjuvant radiotherapy can again be considered if the patient is radiation naive. For moderate and high-grade lesions, WHO grade 2 and 3 respectively, en-bloc resection is similarly the treatment of choice. However, in some cases, negative margins are infeasible. Where they are possible, the treatment paradigm is similar to that of WHO grade 1 lesions, though many clinicians will give stronger consideration to the inclusion of adjuvant and radiotherapy. Where R0 resection is infeasible, however, adjuvant radiotherapy should be considered. Prior studies have recommended using high-dose radiation greater than 60 Gray equivalents. Care must be taken to reduce excessive irradiation of the neural elements, however, with recommended limits of less than 58 Gray for the spinal cord surface, 54 Gray for the spinal cord center, 55 Gray for the cauda equina, 50 Gray for the optic tracts, and 55 Gray for the brainstem. Severe or life-threatening radiation-induced adverse events are reported in up to 10% of cases. In cases of metastatic disease, oncologic resection is infeasible, and en-bloc resection should be accordingly avoided. Treatment is then driven primarily by neurological status. For patients with evidence of tumor-mediated neurological compromise, surgical intervention should be considered. Similar to metastatic tumors of the vertebral column, patients with expected survivals greater than 3 months are the most likely to receive a net benefit from surgical decompression. Palliative radiotherapy may be considered as an adjuvant to help with tumor-associated pain. For neurologically compromised patients who are considered too ill or too frail for surgical intervention, definitive radiotherapy with doses exceeding 60 Gray should be pursued. Adjuvant administration of corticosteroids, such as dexamethasone, may also facilitate better neurological outcomes. However, at present there exists no data to support this. For neurologically intact patients, treatment is dictated by pain. Patients with mechanical pain can be considered for percutaneous instrumentation along with definitive radiotherapy to the primary lesion. Those with oncologic pain alone may receive palliative radiotherapy. We now talk about chordoma. Population-based studies place the annual incidence of chordoma between 0.01 and 0.08 per 100,000 people. Like chondrosarcoma, nearly two-thirds of patients are male and the median age is 55 years. Patients are most commonly white, however racial breakdown is again similar to that of the overall U.S. population. Most patients will have confined disease at diagnosis and metastatic disease is rare. However, when it is present, metastases are most commonly found in the lungs. Within the axial skeleton, the most common tumor location is the skull base, which comprises just over 40% of all cases. The remaining cases are split relatively equally between the sacrum and mobile spine. Overall survival is 68% and 40% at 5 and 10 years respectively, but disease-specific survival has been reported as high as 60% out to 10 years. Median overall survival varies significantly by lesion location and is nearly twice as long for skull-based lesions as compared to sacral tumors. Other positive predictors of survival include localized disease, younger patient age, en-bloc resection with negative margins, and the use of adjuvant radiation. Some recent studies have even suggested that the use of adjuvant, high-dose, focused radiation may better predict survival than surgical intervention. Chordoma derives from the embryonic notochord, a rod of mesodermal tissue essential for neural tube patterning. Under normal circumstances, cells with a notochord involute, leaving only a small population of differentiated cells within the nuclei pulposi of the intervertebral discs. Failure of complete involution results in chordoma or benign notochordal tumors. On gross histology, chordomas appear as lobulated, gelatinous tumors that frequently invade local bone. On microscopy, chordomas appear as aggregations or cords of vacuolized phycilliferous cells intermixed with spaces of myxoid extracellular matrix. Cells stain positively for brachyury and in many cases also stain positive for vimentin, S100 protein, platelet-derived growth factor receptor B, and epithelial markers. Brachyury staining is occasionally negative in high-grade lesions. Here we illustrate some of the imaging characteristics on CT. Present is a CT myelogram demonstrating a classical chordoma of the T12 vertebral body, which shows a heterogeneous lytic blastic lesion with greater than 50% vertebral body collapse. Image on MRI. It illustrates the characteristics of classical chordoma of the mobile spine. The lesion is T1 hypointense, T2 hyperintense, and shows mild to moderate heterogeneous contrast enhancement following gadolinium administration. Definitive treatment in chordoma focuses on maximal safe surgical resection. Where possible, en-bloc resection with negative margins is preferred, as piecemeal resection is thought to produce local seeding and is associated with demonstrably poor overall and progression-free survival. At our institution, end-nasal approaches are preferred for skull-based lesions, posterior en-bloc spondylectomies are preferred for lesions of the mobile spine, and en-bloc sacrectomies are preferred for sacral lesions. Extensive resection, regardless of the level of the neuraxis treated, may result in substantial mechanical destabilization, thereby creating the need for instrumentation. For lesions of the occipital-vertebral junction, we prefer posterior occipitocervical instrumentation extending to at least the C2 level. If C2 involvement is noted or there is significant mechanical instability at the occipitocervical junction, we suggest fusion into the subaxial spine. For lesions of the mobile spine and sacrum, we prefer posterior pedicle screw instrumentation. Mobile spine lesions are reconstructed anteriorly with fibular allograft placed within a titanium mesh cage. Double rods are placed bilaterally because of the lower rates of hardware failure relative to single rod constructs. We feel that the risk of pseudoarthrosis and construct failure is of greater concern than in non-oncologic operations, as the extensive anterior column defect combined with postoperative radiation may produce a state of permanent non-union. Radiation should be considered as a neoadjuvant or adjuvant therapy. At present, focused radiation with photons, protons, or carbon ions is preferred. However, evidence from Europe and East Asia has begun to suggest that heavy particle therapy may provide superior results relative to photons alone. Surgical strategies for chordoma are similar to those employed for chondrosarcoma. Skull-based lesions are infrequently amenable to true en bloc resection and consequently may be reasonably approached with the goal of gross total excision. Given this implies piecemeal resection, we favor the endoscopic endonasal approach as it confers similar rates of R0 or R1 resection relative to the more invasive open approaches. And unlike the transoral and transcervical approaches, it allows access to clival pathology. Reconstruction for post-resection mechanical instability is seldom required. For mobile spine lesions, the staple of treatment is en bloc spondylectomy. As the vertebrae are contiguous to the CSF space, this is not true radical resection and consequently does not adhere to Enneking principles. However, for contained lesions, it is effectively equivalent. Smaller lesions involving a single vertebra, especially those with thoracic spine, can reasonably be treated with a single posterior approach. Post-resection stabilization using pedicle screw instrumentation placed 2 segments above and below the corpectomized level should provide adequate stabilization. For larger lesions, those affecting 2 or more vertebrae, a second anterior approach may be required for en bloc delivery and anterior column reconstruction. These larger, more destabilizing lesions generally require instrumentation 3 levels above and below the resected segment. For sacral lesions, en bloc sacrectomy is the treatment of choice. Morbidity attributable to nerve root sacrifice is generally better tolerated by patients relative to lesions of the lumbar and cervical spine. Consequently, we more commonly consider it for these sacral lesions. A posterior approach allows for both tumor delivery and reconstruction, though the surgical duration may require procedural staging. Lesions with cephalad osteotomies above the S1-2 juncture should be treated with pedicle screw instrumentation due to significant destabilization of the bilateral sacroiliac joints. Double screw, double rod constructs offer the greatest mechanical stability. Placement of the femur strut graft or crosslink across the sacral defect has not been shown to increase pelvic stability. However, prior biomechanical studies have failed to examine its effect on torsional strength. Here we present the treatment paradigm. The treatment paradigm for chordoma depends almost exclusively upon the local invasion of the tumor. For contained tumors, en bloc resection with negative margins is the gold standard of treatment. Where this is infeasible, as in the case of skull-based lesions, gross total resection should be pursued, followed by high-dose radiotherapy using focused photon or charged particle therapy. Adjuvant radiation may be considered for en bloc resection, achieving R0 margins. However, it is not required. For locally invasive lesions, en bloc resection with negative margins is again preferred. However, adjuvant radiotherapy is generally recommended regardless of margin status, most commonly being delivered 48 weeks following surgery. Where the lesion is unresectable or the patient declines surgery, definitive radiotherapy totaling 74 gray or more is the current best practice. At present, there exists no high-quality data comparing photon and charged particle therapy. However, the physics of charged particle therapy make it such that it can produce smaller off-target toxicities. In cases where instrumentation was placed, photon therapy may be favored, as it appears to be less affected by metallic hardware compared to charged particle therapy. For recurrent lesions of the skull base, definitive radiotherapy is the preferred treatment modality. By comparison, for recurrent sacrum and mobile spine lesions, definitive therapy is based upon the status of the previous margins and the patient's radiotherapy history. For recurrent lesions and previously having received R1 or R2 resection, the margins must be considered contaminated and definitive radiotherapy is the treatment of choice. By comparison, for lesions previously treated with R0 resection, repeat resection followed by adjuvant radiotherapy can be considered for radiation-naive patients. Patients having previously received radiation to the surgical bed should receive definitive radiotherapy. In the case of metastatic disease or locally recurrent disease that is unamenable to either surgical resection or definitive radiotherapy, all interventions are considered palliative. Palliative radiation can be delivered to treat tumor-associated pain, and there are several current trials investigating chemotherapeutic options, including PD-1 and EGFR inhibitors. However, cure is unlikely, and care should focus on patient quality of life. We conclude by summarizing the major points of the chapter. First, we note that chordoma and chondrosarcoma of the axoskeleton are exceptionally rare and are unlikely to be treated outside of tertiary care centers. Initial workup should include imaging to evaluate for metastatic disease and CT-guided biopsy to confirm lesion pathology. In patients with non-metastatic disease, treatment is dictated by local invasiveness and the level of the lesion within the neuraxis. Where patients are considered surgical candidates, evidence suggests that surgical resection with negative margins is the therapeutic gold standard in terms of both local control and overall survival. For chordoma, many now advocate for the inclusion of adjuvant or neoadjuvant radiotherapy given the advances in focused photon radiation and the increasing availability of both proton and charged particle therapies. Ongoing areas of investigation include further evaluation of these modern radiation modalities, as well as investigation of possible chemotherapeutic targets for patients with refractory or metastatic disease. To this end, many clinical trials are ongoing, several of which are expected to report results within the next couple of years.